Welcome to Anti-Aging Unraveled with Dr. Lori Gerber. The body is one of the most complicated systems in the universe. Dr. Gerber and her guests explore integrative medicine and cosmetic dermatology, combining traditional medicine, alternative health practices, new innovations, and technology which work together to help you look and feel natural and age gracefully. Now, here is your host, Dr. Lori Gerber.
Hey everybody, this is Dr. Lori Gerber with Anti-Aging Unraveled, and I'm here with another fun topic for you this evening, and I hope to make this interesting. I think it can be a little bit of a dry topic, but it's one that I do hold pretty close to my heart because I do have problems with it myself. So it is the thyroid gland, and if you had listened to my last week's episode, we did discuss how insulin and the metabolic system is all related and how these hormones can all play off of each other. And I think the thyroid is probably one of the most important ones that honestly maybe we've regressed in how we treat it over the years instead of progressed. And, you know, when you look at history, which we're going to talk a lot about history and what has happened with this over time, I think it'll make a little bit more sense as to why we ended up where we did. But in any case, it's how the thyroid gland, how it works, and really, why am I gaining weight? I think my summer topic of choice is really to help people lose weight and to do everything that we can to really get our bodies working optimally. So I'm going to spend the first kind of half of our show doing a little bit of what the thyroid gland is, some history, and then towards the second half, we'll talk about treatments and how the treatments have changed possibly and how they're not necessarily uniform for each person. So on any note, let's kind of talk about the thyroid. So I learned I had thyroid disease in actually end of med school, beginning of residency. And the biggest thing is I felt exhausted. Yes, I was working all the time and I was running crazy hours, but I was physically, like my eyes could shut at a stoplight. And I think that's the biggest complaint that most people have when they have low thyroids or hypothyroid is that they are exhausted. They can't gain weight. Their thyroid is responsible for regulating the rate at which we burn our calories, basically. So when we don't have that capability, we gain weight, even if we're eating well. So it can also raise body temperature. We can maybe be getting hot flashy or feel like we're burning up. Difficulty with regulating our temperature in general. So meaning maybe you're in the middle of the night and you start to sweat in the middle of the night, or you can't tolerate the cold. But it also can affect the way your muscles contract. So a lot of our athletes will complain when they feel like they're not recovering, maybe they're getting muscle cramping, and that's a big problem. The other thing too is it controls the rate at which the dying cells are replaced. So again, that has to do with recovery, right? So we're not recovering or keeping our immune system in necessarily a good enough level that it needs to be. So let's see, we talked about calories, we talked about temperature, weight, digestive system. So the digestive tract is huge in this. And we get a lot of people that complain about digestive issues in my office. And it's one of those things where we can go any number of routes, but we always do look at the thyroid. You know, a slow thyroid will actually slow down the rate at which your digestive system moves. And by the same token, it'll keep you from necessarily having regular bowel movements. That is a big deal, especially for weight loss, right? So we want to be able to digest our foods, get them through our system, and absorb our nutrients. The other thing is we can actually start to have an irregular or a racy heartbeat. And whether that's high or low, it can go in either direction, but palpitations or maybe what we call like a bradycardia, which is a slower heart rate, we can go either direction with thyroid abnormalities. So, you know, when we go to our doctor, I think this is a big question I get a lot is, you know, how come my doctor only checks a TSH? Well, a TSH is a thyroid stimulating hormone. And really what that means is it tells the body to make more thyroid hormone. It is saying, hey, guys, give me some more thyroid hormone here. I need it. And it will go up in response to increasing demand or need. And that is fine to check in many cases. But the problem is not everybody does that whole system work appropriately. So meaning when you have enough thyroid hormone, in theory, it should shut off that TSH. When you don't have enough thyroid hormone, it should turn on that TSH. But what happens when that circuit doesn't work right? It basically, you're checking this number that's not really a true thyroid number. It doesn't make you feel, quote unquote, any better when it's high or low. It's the T3 and the T4, which are actually your thyroid hormone, that really drive how you feel and your metabolism and all the things we just talked about. So the thyroid gland makes this stuff called T4, which is an inactive kind of a more of a generalized thyroid hormone. And then it converts it into T3. And T3 is what we call the metabolically, or I like to call it the metabolically active hormone. It's what we feel. It's how we feel better. And those two things are your thyroid hormone. So we also check something called a reverse T3. Without getting into too much detail, that will tell us kind of if you're able to make T3, the active stuff, from T4, it actually will convert. Now, what are these, T3s, T4s? What does that mean? And, I think the thing to understand for most of us is that they are the thyroid hormones, and the numbers are the amount of iodine they carry. So we're going to get on this topic of iodine, and it's a really interesting topic. And I learned more than I knew about the history of iodine. But T3 means it has 3 iodine molecules, and T4 means it has 4 iodine molecules. In order for us to go from one to the other, we actually have to do a process of deionization, which is literally, deionization is taking an iodine off, or reionization is putting it back on. And really all we're doing is using like an electron transport. We're transporting these things across a membrane, and we're doing molecular biology, right? We're doing the things that we all hate to remember from med school or from school in general. And in order to do that, we need a lot of things. We need vitamin D. We need vitamin A and K2. We need a lot of methylated B12. We also need something like iodine to actually give us an extra iodine molecule. And we need a process called methylation. And methylation in a lot of people can be deficient. So all of these things go into being able to make your thyroid hormone appropriately. And iodine is super, super important. So, 65% of T4's molecular weight is iodine. And we ingest iodine. Okay, that's how it's absorbed. That's how it's carried through the circulation as iodide. Our thyroid concentrates that iodide. So it actually takes that iodide and it concentrates it, and it uses it as a transporter to actually take it off of the T4 and make T3. And every single person needs it. And the problem is the way that we've ingested and taken in iodine over the last several decades, actually, up to the last several hundred years, has really changed. And we need, every cell in the body needs thyroid hormone for metabolism. It doesn't matter where you are in the body. And we produce about 80% of this T4 stuff and about 20% of this T3 stuff. But the cool thing about T3 is it's really, really strong. So the active metabolic part of our thyroid hormone is really strong. It's 4 times stronger than T4. So again, when I talk about what you feel, you get benefits from both. But I think most people feel symptomatically better when they have their T3 levels appropriate. So when we get our numbers checked, and specifically when I check thyroid, I'm checking for TSH, T3, T4. We're checking what we call that reverse T3. And we're checking for antibodies to your thyroid. Because if you listen to any of my last one, I encourage you to do it because it really ties in nicely. We have a tendency to make antibodies to things that are inherent in our own body. That's a problem, right? We're fighting ourselves. Anything autoimmune is not a good thing. And the thyroid is probably one of the most common early on to start fighting. And honestly, we can fight our insulin, and we can start to have these, what I call autoimmune kind of diabetic triads. But thyroid and insulin resistance go hand in hand. So how do we fix this? And well, one, how do we find it? And we have to really look for these antibodies. Antibodies to your thyroid are not normal. You shouldn't have them. So having even some of them, even at a low level, is not necessarily normal. Obviously, the higher your numbers are, the worse you're fighting your own thyroid, the harder or more difficult or worse the symptomatology is. And, I feel like we need to look at that to understand how we're going to replace our thyroid hormone. There are differences in how we replace it, and we're going to talk about that too. So we kind of touched on hyperthyroid or hypothyroid. I want to just touch on hyperthyroid, and that's not something I'm going to go into a lot today, but hyper or overactive thyroid really can mean that you have too much T3 in the bloodstream, that you're overactive thyroid gland. And Graves' disease, which is an autoimmune like stimulation of the thyroid gland, is one. Benign tumors or inflammation of the thyroid gland can cause it. And this can cause weight loss, increased appetite, racing heart. They low or high can cause irregular menstrual cycle. Believe it or not, hyperthyroid can cause tiredness as well, but it can also cause you to be very irritable and very racy. So these are things that we want to look for when we're talking to our patients about symptoms. Obviously taking medication can make you hyperthyroid, but what we're going to talk about in a few minutes is usually that can only happen when you ingest what we call T3. And T3 is called cytomel, and that's a hormone that's only T3. So that can obviously happen as well. So I'm going to kind of go backwards a little bit and talk about why do we need iodine? And we kind of briefly spoke about iodine and the transport chain. And I'm not going to go into really how it all works because I think it's not really necessary to understand that we need iodine. It is a very, very important process in the hormone pathway for thyroid. And without iodine, the thyroid does not function. Now, we've gone through various, I would say, controversial things in history that maybe refute and that have tried to refute iodine necessity over the years. And I'm just going to take you back a little bit because I think this is really interesting. And to me, I like to see the history and the chronological part of medicine because it does. Medicine and history repeat itself. And I think iodine is a very good example of maybe coming full circle. And because really, we've been treating the thyroid since the early 1800s. Okay, so the thyroid iodine connection was found shortly after 1811 when they found that iodine was in seaweed. And 8 years after, so 1819, there was they started using iodine for the treatment of goiter, simple goiter. And goiter is just the enlargement of the thyroid. So when the thyroid would get large, it would cause obviously unsightly, cosmetic effect, but it would also cause thyroid abnormalities. So we started to give iodine to treat this goiter. So iodine sufficiency was basically, one of those things that was commonplace. We wanted people to have enough iodine. Why? Because in our brains at that time, iodine sufficiency or enough iodine equaled a lack of a goiter. So what happened is they started to, in the early 1920s, there was a lot of testing that was started to be done by a gentleman with the last name of Marine. And he literally found that 9 milligrams per day of iodine would help in the prevention of simple goiter for adolescent girls. So, they took this guy's studies and they said, okay, this is amazing, right? So they really said, all right, iodine deficiency is not good. Iodine deficiency causes goiter. Iodine sufficiency, we see that their goiters are all decreasing in size and number. And honestly, people aren't getting sick. It actually decreased the amount of people that were not showing up for school and due to absence and sickness as well. So iodine was kind of the golden child for thyroid at the time. And that really led us to, like I said, the early 1900s, 1970 to 1924, where, we said we have to get rid of iodine deficiency in everybody, basically. So what we decided to do was to iodize salt, right? We all know about iodized salt. And iodization is a process by putting iodine into salt so that when it's ingested, it actually becomes iodide. And, we really pushed this on the population because we wanted everybody to have iodine to get rid of these thyroid diseases. However, what we knew was bioavailable iodine that was needed to prevent what we call cretinism, goiter, and hypothyroidism was about 60 times less than what they were putting, or 60 times more than what they were putting in the salt. So salt was getting 0.05 milligrams per day. Now, this is interesting because why would they cut it back so much? And the reason they cut it back is because there's this fear of over iodization. So we don't want too much iodine, but yet we want to prevent these diseases. And this is where history kind of triggers us to go back another direction. So, we thought, wow, we're going to put salt in all the iodine in all this salt. We're going to encourage people to use salt. And thyroid disease is going to be a thing of the past, especially with goiter. And really when we look at it critically, what they put into salt was about, like I said, 60 times less than the amount that was needed to prevent goiter in the women's study from Dr. Marie. So let's think about that for a minute too. Let's fast forward to now. We encourage people not to use salt. We encourage people to use sea salt. So even any kind of iodine that we were going to get from salt at this point, many people don't get, right? We're not salting anything, especially with regular table salt. And the amount of true iodide that we're getting in salt is very, very, very low. So the way we used to give ourselves iodine, as opposed to giving it in salt, was with something called a Lugol solution. Lugol solution was kind of cool. It was just a dropper. You'd put it in your water, or you'd put it under your tongue, and you'd get it from the apothecary. And we would get about 12.5 to 37.5 milligrams of elemental iodine. That when you put that into a dropper form and you use 0.1 to 0.3 mLs a day, you're getting a lot more elemental iodine. So this was the exact amount of iodine needed for whole body sufficiency. And when you look at all the studies that were done back then, you were able to suppress goiter much more efficiently and thyroid disease much more efficiently than when they put the iodized salt out there. And there was a huge push to get people to use this salt. And I would even call it a propaganda campaign, because really, if you look at even the ads that were out there, it was extremely detrimental to the Lugol solution, and really just pushed you to use salt in general, even though they knew that it wasn't sufficient or enough to be the same amount as the Lugols. So people that were switching over would find that they didn't feel as well. And then obviously we had a rise in thyroid disease still, even though we still had iodine and salt. So, we know it wasn't enough, but it was more than people that weren't taking in anything. So it did increase, the amount of iodine in our body, and it decreased the amount of radioactive iodine that our thyroid would take up, but not enough. So it really represented about less than 1% of the daily recommended intake of iodine. So let's kind of go into a little bit more of the history as we fast forward. So let's talk about medical textbooks. Medical textbooks in the 1930s, again, maybe fast forward 5 to 10 years, basically took all the information that was from the late or early to mid 1800s and really forgot about it, and started to really propagate this idea that we don't need iodine as a supplement or a replacement. That really, hyperthyroid, it really took iodine and completely ignored the thyroidologist's iodine deficiency goiter studies of hypothyroidism, and just said, really, the treatment of hypothyroidism is giving a thyroid extract solution, which is a glandular. It said, hey, let's just give you basically T4, okay, it sounds great, right? But the problem is again, we know the physiologic compound. We know how thyroid hormone's made now. It's T4, it's T3. We need iodine to be able to do that conversion. So even if I give somebody a whole lot of T4 in their body, which is essentially what they're talking about, it's this inactive hormone. It doesn't do a lot. And then you have to still make it into T3. So what happens when you can't make that T3? You never feel any better. You get a whole lot of T4 and you don't have any iodine, and then you can't make any T3. So you're metabolically speaking, you never feel any better. And that's really the problem that started to occur in the 1930s, when iodine became completely ignored. Like I said, it was eliminated from the textbooks. And iodine deficiency they were starting to say that it actually induced problems, more problems than it did good. So that is where we started to have this, what we call iodophobia, or the shift in iodine. And there's a couple of key points to that. And that's probably where I'll go next, is I'll talk about the authors that really, really shifted the paradigm here. And it was really after World War II is really when we really got this scare of taking iodine out of everything. So since we stopped putting iodine or stopped giving credence to iodine and what we like to call iodophobia or iodine neglect, became a systematic attempt to really pull iodine out of everything. And iodine at the time was also used for bread. And it was used as a preservative in bread. And, which is great, right? We get some extra iodine. That's awesome. The problem is when they started pulling iodine out of bread, and actually this became a pretty global effect. They, especially, and the United States was at the forefront of this, that all this misinformation wanted this iodine pulled out, but instead they put in bromide. And, bromide is not good for you either, right? So we're putting in a carcinogenic preservative as opposed to keeping in iodine because we're all afraid of this iodine. So if you really want to know how iodine was killed, there's Wolf and Chaikoff from Berkeley in 1948. And they basically said, and it was obviously a flawed study, but they were putting iodine in rats, and their conclusion was that it blocked the synthesis of thyroid hormones, resulting in hypothyroidism and goiter. Now, meanwhile, they never checked thyroid hormone levels in the rats. Okay, it was a very flawed study, and I've actually gone back to take a look at it. But that's called the Wolff-Chaikoff effect, and how sad that this one study, and this is very common, to be honest, one study changed the way we think about iodine in this country. And the second thing that happened, fast forward about 15 years, is in 1969, Wolff moved to the NIH, the National Institute of Health, like so many of our esteemed researchers do. And when he went there, he basically defined what he called 4 levels of iodine excess. And they were actually completely ludicrous. And in the 1970s, it was so prominent because he's from the NIH and he has this big name that all physicians basically concluded that inorganic, non-radioactive iodine was basically taboo and not a treatment anymore. So they really, this is what they call the Wolff-Chaikoff effect. And it really just paradigm shift in the way we think about iodine. Now, iodine, I feel like, is making a full 360 at this point, right? It's coming back into favor. We are finding out that, there is a way to safely dose iodine, especially in populations with Hashimoto's thyroid, because it's very difficult to get them to start shutting down their antibodies. So we need to get any thyroid that's being produced efficiently. So, there's even some what I would call conspiracy theories out there that say that the pharmaceutical companies knew when iodine was being pulled out of bread in the early 60s, and that they knew that people would become deficient in T4 because every loaf of bread had about 150 micrograms of iodine. So, it's a full daily dose of iodine. And how interesting that maybe they knew and they were able to simultaneously release drugs for T4 replacement. And why is T4 a little easier for the pharmaceutical companies? Some people say that because it's not a true T3, which is that thyroid hormone replacement, there's less side effect profile. You have to make T3 out of T4. So it's a much safer profile to create, and everybody's going to need it, because once you pull that iodine out that people have been used to having and that they need, it will later become the most prescribed drug in the United States, which it did. So, there's a lot of happenstance there, and whether, it's truly serendipity or that they knew what was going on, I guess it's not really for me to decide. But I can tell you that, if one slice of bread was giving you the daily recommended iodine and we pull that out of our daily routine, somebody's going to realize that iodine deficiency is going to create an issue. Okay. So, all right. So let's talk a little bit about, let's see here. So iodine in general, now what we kind of conclude is you need about 6 milligrams for daily intake, and whole body sufficiency anywhere from 12.5 to 50 milligrams daily. So for the thyroid itself, 6, the whole body 12.5 to 50. I would say most of us, when we prescribe it, give you anywhere from 6 to 25, depending on the person. And it really does help to stabilize a thyroid. I would say for people that what we call poor converters, where you can't make T3 from T4, it really helps to have that extra iodine around. I always say it's like having the kitchen sink full of iodine. If you have a lot of iodine, you can pair them up and pull them off. If you don't have a big sink of iodine and it's not sitting around, you got to go find it, which is a lot more difficult. So, when you think about what you're going to take and why you're taking these things, I think it's important to think critically about the pathophysiology and not necessarily about the studies that have been put out there. Yes, studies are important, but they're biased. Sometimes their conclusions are not appropriate for the time, even if maybe they're appropriate for the time. Maybe we didn't know how to do something at that time. So I think these are really important things to remember to go back and critically look at over time. Okay, so let's do a little bit about treatment. Let's like skip to treatment a little bit because I do have a lot to say about this. So there is a lot of evidence to suggest that vitamin C improves iodine transportation. So when we talk again about what to take and how to take it and why we're taking it, we know that vitamin C helps with what we call a defective cellular transport chain. So it helps for iodine to work a little bit more efficiently when it repairs that chain. I think that if we're going to take iodine, we should be taking A, D, and K, which will help the thyroid to work a little bit better. We should be taking vitamin C to help it work better as well, to get it in there. The other things that I think are important are methylated B12. B12 is required for helping the thyroid to make its T3 as well. Without a lot of B12, it's what I call those cofactors, we can't make it very efficiently. So, those are two things that I think everybody should be on that are in addition to your iodine. Now let's talk about the different types of thyroid replacement because there's a little bit of history here as well. So the first thing that came out was what we call desiccated thyroid. And desiccated thyroid is, a lot of people know it now as Armour thyroid. There was a brand that was recently, one of my favorites has been temporarily suspended, which was Thyroid. And these are literally, I like to say it's thyroid gland that's like dehydrated and purified and put into a capsule. Because really it's desiccated porcine, which is pig hormone, and it's got T3 and T4. Why is that important? Well, we're giving you both biologically active materials, right? Whereas the pharmaceutical companies, when we were talking about earlier, they really preferred T4. But if you can't make T3, let's say you don't have iodine, you don't have D, you don't have B12, you don't have A or K, then you're never going to get enough T3 to feel better. So desiccated porcine hormone is what we would call 38 micrograms of T4 and 9 micrograms of T3. Okay. So again, it's that 4-to-1 concentration, but it also has all the other compounds and calcitonin, things that go into making a thyroid work that are in the thyroid gland in this desiccated thyroid hormone. I like it for a lot of patients. Now, there's a lot of controversy over it, probably in the 90s, really. About standard of care, but really it was the standard of care from the 1890s through 50 to 60 years until really 1970 when they started making T4 standard thyroid replacement hormone extract. So initially it was made from beef or pork. They did change it to porcine for it to be a little bit more close to 4-to-1, just like our human thyroid gland. And, it brings us everything we need. So, I think that we have to understand that we're giving you back essentially the entire thing that you're missing, as opposed to T4, which we're going to talk about, which is only one portion. The downsides. It has a shorter half-life. So when we talk about how long it lasts and how long it takes our body to break it down, our body only breaks it down. It breaks it down very quickly. So let's just say, for example, it has a half-life of maybe like 6 hours. In 3 hours, it's cut in half, right? That's really how half-lives works. And every time you have a half-life, it's broken down in half more and more and more. So the shorter the half-life, the less it lasts you in your body. So as opposed to T4 and some of these other compounds, Armour has a shorter half-life. So I do recommend for many people to be dosed twice a day, okay? Because by mid to late afternoon, you may find that it's starting to wane. That's not in everybody, but I would say that is kind of the more common thing. And, I would say that we're taught in med school to use T4 because desiccated thyroid is unreliable and unstable. And we're going to talk a little bit about the history of Synthroid. So I think that is probably a huge misinformation. Yes, can there be differences in the amount of thyroid compound in each desiccated thyroid pill? Yes. Is it safer and more effective than most people feel on Synthroid or a various brand of T4? Yes. So, I think it did fall out of favor for a long time. But the interesting thing is in 1985, the U.S. Pharmacopoeia, they actually revised their standpoint from what they were training in med school and said that Armour or desiccated thyroid were that the content met the standards for stable potency. So, despite them teaching that it wasn't a good sample or it didn't have a stable enough potency, in 1985 that changed, and I think we're finally starting to see the shift in people taking Armour thyroid again. I mean, I can tell you that when I remember when I was younger, one of my relatives taking Armour thyroid or a desiccated thyroid hormone, and I went to med school, I had never heard about it until I came out and had a couple of people that were on Armour, and I didn't really know what it was. So again, I think it's interesting to see how it's shifting. And so let's just kind of do a little bit of the studies on the desiccated thyroid hormone. I think they're interesting. So in 2018, there was a survey of 12,000 patients being treated for hypothyroidism with both levothyroxine, which is T4, T4 plus T3, which is levothyroxine and liuthreonine. And they found that people, and also with what we would call desiccated thyroid hormone, they found that people taking the desiccated thyroid were overall happier with their treatment than the other two types of therapies. So, and they reported improvement in their memory, weight, fatigue, and energy. And, in 2013, there was a similar study comparing them, and they found that for weight, that at the end of the study, there was not a lot of difference between heart rate and blood pressure and that kind of thing, and cholesterol, which we really wouldn't expect. But there was a 3-pound average difference and decrease in their weight on the people that were on desiccated thyroid hormone. And that was in 16 weeks. So we're not talking about huge amounts of time here. We're talking about over the course of 4 months. So, this is an interesting thing, not even 4 months. So this is an interesting thing to say 3 pounds. I mean, 3,600 calories in a pound, that's pretty significant. So I would caution you to switch yourself over to T4. I would see a lot of people that go to their primaries that have been on Armour for a long time, and they switch over to T4, and their numbers, quote unquote, per their doctor are okay, but they're told that they're fine, but they don't feel as well. So I think that's a really interesting thing. So, and by the same token, let's talk about T4 on the other side here. So T4, again, has to be converted to T3. It is what we would call a thyroid hormone by itself. It's not desiccated. It's just a purified thyroid hormone that's produced and manufactured. Now, if you take that T4 and you put it into the body, again, if you can't convert it to T3, it's not going to be very usable for you. Okay, what does that take? B12, vitamin D, iodine, A, K2. So these are all things that go into being able to make your thyroid hormone active. Okay. So it was first available in the 1950s. And, at first, to be honest, they were reluctant to prescribe it because it didn't have the T3 that desiccated thyroid does. And believe it or not, they were worried that people were going to end up with T3 deficiencies. But let me ask you a question. If someone doesn't check a T3 level, how do you know if they're T3 deficient? And I think that's the big frustration for a lot of thyroid patients that become educated. Because what happens is that you should be getting your T3 checked. And your doctor is just checking a TSH. All the TSH does is tell you that your pathway is working appropriately or that your TSH is normal. It doesn't tell you, again, that your T3 is normal. So when I order labs, I order a TSH, a free T3, a total T4. Why? Again, we need to know the whole picture, okay? So where did Synthroid come from? And I think this is one of those things that we look back and we say, all right, when Wonder Bread took iodine out of their breads, did somebody know that this was going to happen? And did they create this T4 stuff so that they could make billions upon billions of dollars, as it was the number one prescribed drug until the statins came along for cholesterol. So Knoll Pharmaceuticals originally put out T4, and I found this story to be really interesting because, again, we all give these thyroid, desiccated thyroid, not we, other people give it a bad rap. And I get asked a lot of questions as the FDA recently pulled Thyroid off the market, which is a desiccated thyroid, for lack of potency standards, meaning they had some variation in their supplementation. Now, let's talk about what happened to Synthroid, which is now owned by Abbott Labs, but it was owned by Knoll Pharmaceuticals. And Knoll basically came out with Synthroid, and it had come out so long before, right, before Knoll had it, that it was almost, it was grandfathered in. It was considered it was before the FDA, right? So it's kind of grandfathered in as an accepted form of medication. And basically, the FDA finally, in I think it was 97, issued a notice saying, listen, all thyroid drugs need to get approval. We're over this. We're done. We know you're grandfathered in, but you have to get approval now. And they actually weren't going to even require clinical trials at that time. Just approval that your potency standards were up to where they needed to be. So, when Knoll first got this information, they said, nope, we're not doing it. We refuse. And they petitioned. So they petitioned for a long time. And when they finally got the verdict, they wanted to be petitioned for what we consider generally recognized as safe, which means they don't get approval and they can keep going on their merry way. Well, the FDA refused or rejected their request and said, we're gonna basically pull you off the market. We're going to cut your distribution down. But the problem was, by the time this happened, they had already sold their medication to Abbott. Now, this is obviously done intentionally. And when you go back and you look at the testing that was done for Knoll over the years before the FDA required the approval, there's multiple reports of what we call sub-therapeutic or potency standards issues. And again, this is in the late 90s, right? So this is not, we're not talking about in the early 1900s. We're talking about in the 90s, and basically they were not able to make a consistent drug that was safe and the same dose all the time. So FDA finally said, well, we need you to prove that it's going to stay the same dose for 6 months. And when Abbott took it over, Abbott said, well, we're not going to fight you on this. We'll do this. And they said they would submit to, by I think it was in August of 2001, we will submit to you guys to get approval. And they eventually did. But when you look back at the data on Synthroid and the potency standards and how they were not able to keep consistent potency over time, I think it's really interesting that we chastise these desiccated thyroid companies for not being able to do so. Meanwhile, those companies have been around since that drug since the late 1800s. So, there's everybody absorbs these compounds differently. I think what's really important to talk about with desiccated thyroid is when we give back a desiccated thyroid to somebody who's what we call Hashimoto's or autoimmune, we find that sometimes they can't tolerate it because they make antibodies to it. If it looks like your own thyroid hormone too much, your body starts fighting it. So, there are definitely reasons to, what I say, either change up your thyroid replacement or maybe even combo it where you use a little bit of one and a little bit of the other, because your body is going to want to fight this thyroid hormone because it looks so similar to your own. And that's obviously a frustrating problem. Nobody wants to have that happen, especially when it's working for them for a while, but it does happen over time to a lot of people. So in those cases, I will switch them to a T4 and usually a T3. So let's talk about T3 for a minute. So T3 is, we call it Cytomel, but that's just the trade names. And T3 is literally just T3. It's biologically active, metabolism boosting T3. And it's in a little tablet form. And this is taken usually twice a day as well. It does have a pretty short half-life. And it is similar to Armour in that it doesn't last a full day. So we dose that twice a day, and it comes usually about 5 milligrams. We do 5 or 10 milligrams twice a day. What can it do? Well, this is where we run into maybe some issues sometimes of raciness, palpitations, not sleeping, and those kind of things. So I think what you really need to think about when we replace thyroid hormone is looking at symptoms, ranking where they are, and making sure none of them get worse and that you're improving symptomatology. Numbers being different on a lab test doesn't really tell me anything. The other thing that I think people don't understand is when you test for thyroid hormones, when you're looking at desiccated or at Armour, again, they have a very short half-life. They're not staying in your system for prolonged periods of time. So when you're checking labs and you're checking morning labs and you're checking them fasting, you're not getting a level of thyroid hormone that they're feeling when they take their pills. So you're getting what I call a trough level. You're getting the lowest level when it's already out of their system. So I do have people take NatureThyroid, Armour Thyroid, Cytomel about 3 hours or 2 to 3 hours before their lab tests, in the understanding that it might be high, but I want to see if they're absorbing it. I want to see where their peak is, because if I know where their peak is, I can know where they're falling to approximately. And I also want to know what, if they're making antibodies and that kind of thing. So those things are really important to me. Our Synthroid has a longer half-life, so that will actually build up in your system over time. That is one of the better qualities of it, right? So Synthroid or T4 in any form, Tirosint is another one. There's a bunch of them. They will actually, you don't have to have someone take them before their lab tests, okay? So that to me is something they would leave off. They'd come in with that fasting. And that's something I think people make a mistake about a lot. And, it's something to ask your doctor when you go to get checked, because I think that one of those things to remember is not all doctors are knowledgeable in this. And in order to do this efficiently, you're going to keep coming up low, generally speaking, for the Armour and the Cytomel if you just take them in the morning, especially because you're going to be going 24 hours without taking them. If you take them in the afternoon too, you might get a little bit of a blood effect, but for the most part, it's going to still come up low. Okay, so let's talk a little bit about iodine replacement and what happens if you take a little too much iodine. So iodine is a really wonderful detoxer. So it's great to clean out the liver. It's great to bind heavy metals and excrete them. So we start off taking it very slow. And the reason I do this is because I can tell you from experience, I had it myself. Iodine, when it binds up things and gets rid of them through the liver, if your body is super toxic and it doesn't want to get detoxed very quickly, you can feel lousy before you get better, meaning you can have headaches, achy, fevery, feeling yucky. And that's because the liver is not ready to go through all of that clean out. We know that that iodine used to be dosed basically until you had diarrhea. So you'd actually take the Lugol solution and you'd keep adding drops until until you actually had gastric symptoms, and then you'd back off. So it's similar to the fact that we do it, but we start slow so that you don't get those symptoms. But if you get any kind of GI upset or, in, like I said, fevery, achy, headachy, then you back off of the iodine. Iodine can also cause some some palpitations as well, because it can raise the thyroid. So we do want to make sure that you don't have any raciness and don't have any shortness of breath or increased anxiety or anything like that. We now use an algae-based, kind of a seaweed-based iodine, at least in my office. I, way back when, used a little bit of Lugol solution. I was probably a resident when I did that with a doc. And Lugol's worked great. It's just a little bit messy. And it can be a little bit just hard to do in general. So there are places that do a liquid iodine that you can use. And that does a nice job as well. All right. So let's talk a little bit about how often are we going to recheck labs? So I would like to recheck labs in general. People tend to get them done at 6 to 8 weeks, 8 to 12 weeks. And again, when we're working with some of these shorter half-life drugs, I think we can actually check them a little bit more quickly. You'd be surprised at how in 6 to 8 weeks, maybe even less, 4 to 6 weeks, we can see a difference in the thyroid hormone with desiccated thyroid, iodine, B12, vitamin D, and A and K, and just adding, like I said, the desiccated thyroid hormone. If you're doing T4, T4 really does take a little bit because you have to convert it to T3. So you're going to find that timeline is going to be closer to your 3-month mark. And, sometimes when people are pretty bad off, they don't want to wait that 3 months. So I do find for people satisfaction, if you will, and feeling better more quickly, that Armour thyroid is a really good idea. I also use a brand called EcoThyroid, and EcoThyroid is also desiccated glandular. And that is a bovine based, and it's wonderful. It's New Zealand bovine. And that's a really good one as well. It is by PHP Labs, and it's wonderful. So if you guys have any questions on that, just message me on my Facebook or my Instagram, and we can kind of look into that. So, let's go back a little bit and just talk about symptoms and them being difficult to tease out. So when someone comes into me and they're saying that they have their hair is falling out, they are exhausted all the time, they're gaining weight, they're constipated, it's a really generic statement, right? These are things that can be a lot of problems. And for the most part, I would say that almost everybody has what I would call a subacutely low thyroid, where their thyroid is just, especially as the age is just not working as well as it should. So optimizing all the things that go into making your thyroid hormone are really important. It's sometimes not as important to get the numbers up as it is to get the cofactors back. So getting that B12 on board, that D, that C, that iodine, and when I say B, please make sure it's a methylated B. All of those things are so important, the iodine and even maybe putting back some desiccated thyroid. But even without that desiccated thyroid, getting those compounds back will help your body work more efficiently. And then in turn, it'll help the insulin become a little bit more sensitive. It might even help your sex hormones to work a little bit better. So, I think that's the key, is really starting. You don't even need to get lab work for some of this. Getting the gut in check, make sure we work on gut health and getting the inflammation down, because all of these things are connected. It's a metabolic triad. It's a metabolic pyramid. And when that starts to happen, the immune system gets bad, and then you start to get other immune system issues, and we need to work on that. So on my website, I do have a bunch of products that you can start without necessarily having to do my program. And I think that's one of the questions that I get asked most often. Do we have to do your wellness program to get help? And I would say no. You can listen to my podcast and my radio program, and you can understand that there's really simple things that you can do that really can help. And when your gut doesn't absorb your nutrients, that's a big one. When your immune system is on overdrive and fights your thyroid, that's a big one. When you don't have the cofactors necessary to make your thyroid hormone, that's huge. So you can get the D-Bomb, which is on my website, for your vitamin D and your A and your K. You can get your methylated B12, which is just called B12. You can get the Gut Shield or the Gut Calm, which is in chocolate and vanilla. I'm actually drinking my chocolate one right now for those of you watching. That will help to calm down the inflammation, help you with absorption, help the immune system. So, and iodine I can get you separately as well. That's one thing I don't have on my site, but we have it on our website with our full script. And that iodine we have is a 6 1/4 or 12.5 milligram. And it helps so much for just getting started on your thyroid hormone regulation. So, and there's other things to think about with thyroid hormones, like genetics and viruses that can cause it. And is it being affected by Lyme or anything like that? And that absolutely can be the case. So we want to make sure there's no other confounding issues that are aggravating this. So, when it comes to all of these things, do you have to get labs drawn? No. Can you start with just the easy things? Yes. And I'd highly, highly, highly recommend that. And then if you just want to send me a message to ask me questions, I'm more than happy to answer them to the best of my ability. When it comes to consults, we can do a consult pretty easily. There's an intake on my website. It's mydrlori.com, and you just click on that and you just go to the link and you do an intake. That intake comes right to me. It doesn't go to anybody else. And the great thing about that is I can take a look at that, and we can, even if you have existing labs, you can upload them and we can see if there's anything that we can do to help. Because there's sometimes there's enough information already out there that you've given me to be able to come up with come up with a game plan without necessarily having to get more information. I think it's key, guys, and I'm going to kind of start wrapping it up with this. We need to critically think about what is going on in medicine, in our world, and it's just in life in general, and not necessarily follow blindly what someone is telling us, and critically think and examine. Because if we had critically examined, let's just say the Wolff-Wyckoff phenomena study, when I looked at that and realized that people actually took this as fact, that iodine was creating these hypothyroid conditions and these goiters, when they didn't even measure thyroid hormone to figure this out, I think it's crazy. So we need to critically take into our own hands what is going on, look at it, think about it, do the research, figure it out for yourselves. Because when you end up at my doorstep, generally speaking, you've been frustrated because you've been in so many other offices and not had success. So to have success, you need to take control of your own health, and you need someone that's going to listen to you. So, this is something that I think is crucial to healthcare, and honestly, our world in general is just really understanding how things work and not just being judgmental without understanding it. So, if we hadn't had this Wolff-Wyckoff situation, we might never have been in a situation where we said iodine was bad for us. And to be honest with you, if our thyroids have iodine and we're basically saturated, any radioactive iodine that's out there, we're not going to absorb. And that actually was a big thing during war, is that, you'd have iodine pills so that you could take the iodine so that you didn't end up with radioactive iodine in your thyroid, which, if we think about it, is pretty significant, right? We want the iodine there so that we can't uptake something else and put it in its place that's carcinogenic. So I'm going to close on that, guys. So mydrlori.com, mydrlori.com. Just go to the wellness intake and fill it out, or you can go to the shop on there and start grabbing some stuff to optimize that thyroid and get your metabolism back in check. All right, so we'll see you next Wednesday night at 6 to 7 p.m. Eastern Standard Time. And this is Anti-Aging Unraveled with Dr. Lori Gerber. Thank you.
Thank you for tuning in to Anti-Aging Unraveled. Be sure to join Dr. Lori Gerber again next Wednesday at 3 p.m. Pacific Time and 6 p.m. Eastern Time on the Voice America Health and Wellness Channel. We'll talk again next week and keep you aging gracefully.